Hi, everyone. Welcome and thank you for attending this month's webinar presented by Drs. Anna Rule and Kirsten Koehler. Their talk is entitled Above and Beyond, when we ask personal protective equipment to be community protective equipment. My name is Nicole Tulvey. I am the chair of the membership committee for the International Society of Exposure Science, and I will be moderating this webinar. For those of you who are not society members, please consider joining the society as we offer many benefits, including exclusive access to this recorded webinar and presentation after today's live session. Okay, before we get started, I have a few quick housekeeping notes. In the upper right side of your computer screen, you will see the control panel. Please note that the webinar is in listen-only mode. Throughout the presentation, you can type a question or comment in the question section, and we'll review those at the end of the session. If you're having any technical difficulties, please put them in the chat box and they will be monitored throughout the webinar. And then we'll do a Q&A at the end of the presentation. So as I mentioned, today's speakers are Drs. Anna Rule and Kirsten Koehler. So let me introduce Kirsten. She's an associate professor in the Environmental Health and Engineering Department at Johns Hopkins Bloomberg School of Public Health. Her research goals are to improve exposure assessment methods to inform occupational and public health policy. And her research interests include improving spatiotemporal exposure assessment and investigating the influence of microenvironment on personal exposures. Dr. Anna Rule is an assistant professor in the Department of Environmental Health and Engineering at the Johns Hopkins Bloomberg School of Public Health also, where she obtained her master's degree in health sciences and occupational health in 1996 and her doctorate in environmental health sciences in 2005. Dr. Rule is an expert in exposure assessment of airborne, environmental, and occupational hazards, including agricultural, urban, and nosocomial environments. She is currently working with a group of experts to develop personal protective equipment guidelines for the WHO. With that, I will turn the talk over to Drs. Anna and Kirsten. Thank you.
Thank you, Nicole. Thank you, everybody. Welcome, everybody. So let's get started because we have a few slides to go. So first, we wanted to start with a brief overview of what we know about how SARS-CoV-2 is transmitted. Because we know that the virus is transmitted primarily person to person, but there's been a little controversy regarding, small aerosols or big droplets. So we know that the virus, as many other airborne respiratory viruses, is transmitted by respiratory droplets of many sizes that are emitted when a person talks, coughs, or sneezes. Some of the larger droplets can travel a few feet in the air and can infect someone, and that is what we call droplet transmission. Some of the larger droplets deposit on surfaces and can remain infectious for several days, and this is what we call fomite transmission or indirect transmission. And the smallest droplets can stay suspended in the air, and if they contain virus, they can be infectious for several hours at long distances, further than the 6 feet. And this is what we call aerosol transmission. So this is important to keep in mind because even though we don't know the relative importance of each of these mechanisms, we appreciate that all three are possible, and people are likely getting infected by one or all of them. We also know, which is very important for this disease in particular, that between 40 and 60%, depending on the study and the literature reviewed, between 40 and 60% of the infected people are asymptomatic. So it's impossible to know who is actually infectious. So we started thinking about this question way back in maybe at the beginning of March, when there was some indication that some countries that were wearing masks, people were wearing masks, were having some good, I guess, outcomes. So what kind of masks were available was very variable. Who needed to wear the masks, and could they be reused? And since then, some new CDC and WHO guidelines have now recommended that everybody wears a mask in public. So some of those questions are resolved. But so in order to understand the importance of masks and the appropriateness of masks, I think we need to first establish some basic common ground regarding airborne particles. So here we have a a little scale that goes between 0.01 micrometer to 100 micrometers. And 100 micrometers is more or less the diameter of fine sand. Pollen falls in the middle there in around 20 micrometers. And keep in mind, these are ranges. Of course, there's not a specific size, but E. coli and other bacteria fall right around 1 micrometer. Between 0.8 and 3 micrometers is what we consider a lot of the bacteria. Cigarette smoke is on the smaller end of the spectrum with 0.1 micrometer or 100 nanometers. SARS-CoV-2 falls right in that range, also at around 120 to 150 nanometers. And of course, soot is one of the smaller particles at around 30 nanometers. So in a very interesting paper, I don't remember what year, but a couple of years ago, Dr. Lindsley at NIOSH and his colleagues characterized particles from a cough. And they have a cough simulator, so this is not from a person, but they have a range of different ways to generate the coughs. And as you can see here on the, I guess, the right side of your screen, it's plotted again, the count on the y-axis, particle count, so number of particles, and on the horizontal axis, there's the particle diameter from 0.1 to 100 micrometers. And you can see that most of the particles fall, as for every aerosol, fall in the lower end of the size distribution. But that same aerosol, when you consider the volume of the particles, those particles actually, you can see these particles around 10 micrometers that actually you cannot see in these graphs. It's not like they're not here. It's just that they, by number, most of the particles are in the lower end, and by mass or volume, the particles are now appearing in that range. So they calculated that this volume medium diameter around 8.4 micrometers. So this huge range of particles have different behavior in air, and they move in different ways. And each of these mechanisms that we have here apply to different particle sizes in different ways. So the most important for bigger particles, for supermicron particles, is gravitational settling. And this is why we say that big droplets that we are breathing out really fall within a few feet due to gravity. Then impaction is the most important for the smaller end that are hard to capture in a filter, or what we call particles that are follow the airstream, but the bigger particles actually don't make the full turn of an airstream and may be impacted into a surface. Then diffusion applies to the smaller particles. This is more important for the nano-sized particles, and they just bounce around by molecules. So it's very erratic, and eventually they will hit either another particle or a surface. And then interception, which is just somewhat important for all sizes, and particles just intercept or get stopped by another surface. So all of these mechanisms play a role in how we filter particles out of the air. And this is a general graph that if you see again on the horizontal axis, we have the particle diameter, and the collection efficiency of the filter on the Y. And so for smaller particles, you see that 100% of the collection efficiency is mostly due to the diffusion of particles. And that drops down as the particles get bigger. And for bigger particles, most of the mechanism is gravitational settling or impaction right around a couple of 0.2, 0.3 micrometers. And there's a range of particle sizes, right around so between 100 and 500 nanometers, that are just hard to capture with a filter. They have enough inertia that they go through, and they don't have enough mass that it's not captured by diffusion or other, like the other smaller particles. So we call this the most penetrating particle size. And this is important because this is the size that we use to test or to evaluate filters. And that doesn't mean that the bigger or the smaller particles don't get captured. It just means that this is the hardest to capture. And I was talking to Kirsten yesterday. She said, and it's actually pretty hard to get this bad of a filtering, like 80%. But this is, I guess, at a high velocity. So you want particles at this size the filters to be very efficient at that size. So when we were thinking about this question, can a homemade mask protect me? Back when nobody knew exactly what homemade masks were doing. As aerosol scientists and occupational health professionals, we were thinking about this question in the hierarchy of controls as a framework. That we use this framework to protect workers, to decide which are the most effective controls. And so as you can see here, and most of you I'm sure are familiar with this framework, we have the most effective controls on the top of the pyramid, and that's where you want most of your controls to fall if possible. And then the least effective controls at the bottom. So at the top we have elimination. So the most effective way to eliminate a hazard is eliminating it from the workplace or from the environment altogether. And we thought that social isolation was doing that, having everybody in their homes, and if you have an infected individual, just removing them from the rest of the non-infected individuals is a way to eliminate the hazard from the specific environment. Then substitution is actually not applicable for any of the biological hazards because you can't substitute one virus for another. That doesn't work like that. And then engineering controls we have used for many, many years in occupational health to remove the hazard, like physically. So ventilation controls is one of the most efficient ways that we know to remove contaminated air from the breathing zone of a worker, and also putting physical barriers, which are being done a lot right now in supermarkets and bar tailors and that kind of thing, to prevent some of that face-to-face contact between people. The next level of control is administrative controls, which we've all been doing, for a couple of months now, which is work from home, or if you have to go to work, stagger the schedules, do a lot of hand hygiene, and this sort of change in practices that we call administrative controls. And at the bottom of the pyramid is personal protective equipment, which include masks, gloves, respirators. And it's at the bottom of the pyramid because their use is completely out of control of the wearer. And there's many things that have to be taken into consideration, like availability. There was this huge shortage, so even if you wanted or needed an N95 or a mask, you couldn't get one, or you have to be properly fitted to be able to use the mask or to be effective. And we'll talk a little bit, or maybe we won't talk a little bit about gloves, but that's a whole other issue. So there are two main reasons to wear a mask. And we're going to talk a little bit about this. To protect myself from inhaling particles that may contain a virus, and we call this personal protective equipment. This is a term that we're all familiar with. But also, we may wear a mask to limit the number of particles that potentially contain a virus from being emitted. And so it's this second case that we are calling community protective equipment. And this is especially important, as I was mentioning, because up to 50% of COVID-19 infections are potentially asymptomatic. So it's impossible to know who's infected. You're not going to be coughing, so you can't, like stay away from the coughing person because there's no symptoms. So N95 respirators are made of special material that removes at least 95% of those most penetrating particles that we were talking about. They are manufactured to fit with a tight seal around the nose and mouth, so there's no air or small particles escaping or entering that mask. Healthcare workers that are in direct close contact with infected people actually need these. There's no way for them to social distance themselves or put other controls, even though ventilation in hospitals is pretty high. But this is like for the close contact before the particles are removed from the air. There's this question that I think by now has been more or less resolved, that can N95 respirators be reused? Even though it is not recommended for daily, everyday normal use, I guess, because they were not made for being reused, there are several decontamination methods that have been proven effective in this shortage situation. So heat treatment at around 70 degrees C for 30 minutes. UVC radiation works, but it has to be a pretty specific wavelength and power and time. Otherwise, you don't have the contact time, the virus is not going to be inactivated. There's also treatment with hydrogen peroxide gas that the FDA has been approving, and it involves big rooms and it has its own set of hazards, so it has to be used carefully. And time, several studies have shown that the virus cannot survive more than 7 days. I think 5 days is the maximum, but let's say 7 days for to be safe. And so if you had only need for a mask for a short period of time during your day, then maybe you can have the mask just stay out there for 7 days, or if you have 7 masks, reuse one each day. So this is one of the methods that won't affect the fit of the respirator. They won't compromise the elasticity of the elastic bands. So we think it's an easy way, especially low tech, that can be used in low resource situations. But always keep in mind that the fit test needs to be repeated after each disinfection. There's also this question about the N95s with valves, and these I think is particularly important for this virus. These respirators were designed for occupational environments with high dust or fume concentrations, and in occupational hot environments, so they are a little more comfortable to wear. There's less condensation. The valve seals when you inhale, but the valve completely opens at exhalation. And so there is no filter for the exhalation valve, and aerosols and droplets potentially containing viruses can escape the valve. So these have never been approved for healthcare settings, and so therefore they are not adequate for protecting the community. So if you're wearing one of these masks, you should for sure also keep your 6 feet separation to help with reducing the hazard, and also the elastomeric half face and full face respirators have this valve also in the front, so they fall into the same category. Then surgical masks are also made of special material. They're designed for healthcare environments to prevent or to protect the worker from splashes and direct coughs, big droplets, but they don't provide a seal around the nose or the mouth, so the smaller droplets may still be inhaled or exhaled. Surgical masks are good to protect the nose and the mouth from larger droplets, but if you're in the case of COVID for the community, social distancing is actually equally better, or at least to be used in conjunction with it. So we consider it's adequate as community protective equipment. the same as homemade masks. Homemade masks are also not protective, not personal protective equipment, but maybe adequate as community protective equipment. They remove some virus-containing droplets, but not all of them. So using these will expose people to some risk. So having this social distancing will help, add a different level of protection. As with every PPE, no, there's no training. I don't know exactly why this bullet is here, because there's no training for wearing a mask. But you should wear the mask on top of your nose, and you should make sure that it covers all the way to the bottom of your chin. And we know some people are not wearing them correctly. But like I was saying, masks are not 100% effective, and so social distancing and stay at home practices are also required. So there was this very good study done also a few years ago, I don't know, 2012, I think it is, that evaluated the efficiency of different materials to be used as homemade masks. So here's the reference for those of you who are interested. And we have here they tested different media or different types of fabrics. And this is the penetration efficiency of particles at that most penetrating particle size, which is generated with a sodium chloride aerosol. And they tested at 2 different velocities. And you can see here, barely see, but they also tested with an N95 as a comparison to have like a gold standard. So your N95 here has almost zero penetration, even at the higher velocity. And of the 3 other fabrics, there was the best one had penetration of 40%. So you still have like a 50-50 chance, which are not great odds in my opinion. And then T-shirt, which is a lighter material, pretty much had no filtering. So particles penetrate freely in and out of the mask. The towel, which is a little thicker material, helps filter a little more of those particles, but still, 50-50 chance. And scarves actually also were tested. And an interesting thing to note on this other panel on the right is that these are size selective. So at the bottom here, you have the N95 this panel is for low velocity, high velocity, low velocity, high velocity for towels and for scarves. And it's interesting here to note the scarf has the relatively low penetration at the lower particles, which is probably just electrostatic and those diffusion forces. But it also depends on the type of scarf. So they tested different materials. So the bottom line is you cannot stop the aerosols or 100% of the aerosols. So there's got to be definitely some risk. And recently there has been some studies evaluating materials and compared to N95s. And we noticed that they are very uneven. And so we wanted to give some guidance for interpreting some of these results. If they are evaluating and comparing an N95, and they show that an N95 doesn't remove at least 95% of the particles, then something's wrong with their methodology. So please question these kinds of papers. Flow rate is very important when you do these tests, as well as other parameters, how you generate the aerosol, how you condition the aerosol. There's a whole methodology to do this experiment. And so if you test them at a different or lower flow rate, you're gonna have this bias. They appear that the mask or the material is being more efficient than it actually is, and you might send the wrong message of protection. So just kind of like to recap best practices for homemade masks, which I think by now everybody is doing. You know, wash your hands often. If your mask has ties, secure them firmly. Do not touch your mask on the face, and wash your hands frequently. Wash your mask every time you remove it. Wear a clean mask every time if you need to go out, and always still maintain that social distancing, which is very important. Face shields. Face shields should not be used by themselves. We don't consider face shields PPE or community protective equipment either. Aerosols, both inhaled and exhale, can go through the sides and through the bottom of the face shield, no matter how well around the face they go. There's just not a good seal. So they were designed to have been used for years in the healthcare industry to protect from droplets, big splashes, coughs and sneezes. They protect the eyes, that's for sure. Easy to clean, no question about it. And they may increase the use of a respirator or a surgical mask because they protect from those splashes, so you can use your mask a little longer. There's one study that, as far as we are aware of, Dr. Lindsley at NIOSH again, and they tested against big droplets. They did not test against aerosols, and they did not test it as source control. And in their conclusions, they say these cannot be used as a substitute for respiratory protection. So, so this is important to keep in mind. I'm actually going to skip this one because it's just a summary of what I just said. And I want to give enough time for Kirsten to talk about her modeling. So as a wrap up, we have these very simple, but we think very easy to understand schematic, where we have personal protective equipment on this side on blue. So these are equipment that are meant to protect the wearer. Even the ones with valves are going to protect you, but they're not going to protect somebody in front of you. So then we have on yellow here community protective equipment. So there's minimal protection from submicron particles, both in inhaling and exhaling. So physical distancing is required both for the community protective equipment as for these personal protective equipment that have these exhalation valves. And the only ones that we can figure out, if you have, if any of you finds another one, let us know, that is both good for the community and personal protective equipment, or CPPE, are the N95s without valves. So I put the face shield here in the corner just to remind myself, to remind you that they are not PPE or CPE. And so Kirsten is going to now talk to you about this modeling.
Thanks, Anna. So I'm Kirsten Koehler, and I am taking over for the second part of this presentation. We wanted, in thinking about personal protective equipment and community protective equipment, try to put that in the context as people who work at a university of what the potential role of aerosol transmission is in a classroom. And specifically, we wanted to answer the questions: what was the probability of an infection in a classroom setting? How can we use face coverings to help minimize that risk? And how long should we wait between classes? And so we've done this modeling, sorry, next slide, Anna, using an approach that was developed by Shelley Miller at the University of Colorado in Boulder and her colleagues, where they used a relatively straightforward model to be able to estimate the transmission of SARS-CoV-2 from this Sackett Valley Corral super spreading event. And a really nice thing about what they've done, even though this paper is still under review, is that if you go to this tiny URL here, you can actually pull up a spreadsheet that allows you to play with their model and to test different things. And so while there are, of course, some simplifications that are made in this type of modeling, they can really give you a way to kind of compare two different scenarios and see which one has relatively more risk. Next slide, please. So we took this model and I actually programmed it up in MATLAB. If anyone is a MATLAB user, I'm happy to share that code with you as well, to be able to look at a range of different conditions more simply than doing it in Excel. So the major assumptions that are included in this model is first that the approach assumes that the social distancing limits are in place, and so all faculty, teachers, students will be maintaining at least a 6 feet distance from each other, which really limits the impact of the droplets and allows us to focus on the risks due to aerosols. So we make the following major assumptions following their methodology. Basically, first, that there's a constant rate of infectious particle generation. They talk about this as being from one infected person, which I think is the case for the Corral event, which was very early on in the pandemic. But now I think because of an assumption that we'll talk about more later, we could think about this as just a constant infectious rate across all potentially infected individuals. There's no prior infectious material in the room before the class begins. The latent period of the disease is longer than the length of the model. So basically we're modeling here a single kind of class period in which if somebody becomes infected during the class, they're not helping contribute to the transmission of infectious material, which is probably reasonable, at least in the context of classrooms. And then a big assumption that we make is that the infectious aerosols are evenly distributed throughout the room. So this is a reason to focus on the aerosols as opposed to the larger droplets, is that aerosols have been tested in many situations. These types of models are commonly used in occupational environments, and it found that those smaller particles do generally relatively quickly become well mixed throughout a room, as well as more recent computational fluid dynamic simulations also showing that relatively quickly things become pretty well mixed around the room. We also assume that the infectious aerosols are removed by a first order process that includes, in our case here, we're considering ventilation, where the air changes per hour, which we call ACH. The deposition of particles to the ground and any other surfaces, so this accounts for both diffusion and gravitational settling, as well as viral inactivation. And so we want to consider a range of conditions that might be encountered in different classroom settings and see how the impact of wearers of masks, both from the side of the person who's infected wearing a mask, as well as the people who are susceptible wearing masks, and how that can impact them. So to do so, we first need to figure out the probability of infection. That's going to be our ultimate goal. And to do so, we need to model the average number of quanta in the room. And so we're thinking about this as kind of related to the infectious dose of the particles. So to be able to calculate the inhaled number of quanta, we first need to assume the concentration airborne in the room, which is a function of the emissions rate, which is certainly not a well-known parameter for SARS-CoV-2 and likely varies very substantially across individuals, but we can make some assumptions there. L, I've called the accumulation of all the different loss processes, the ventilation, the deposition, and the viral inactivation, and then D, the duration of the class. And so when we have that, then we can account for the breathing rates of the individuals, the average concentration of quanta in the room, and use that to calculate the number of quanta inhaled during that class period, and model the probability of infection, PI, as 1 minus the exponent of the minus number of quanta inhaled. So this goes from, very small numbers of quanta being inhaled, having basically zero risk, up to 100% probability of being infected for very large numbers of quanta. Next slide, please. So we considered a range of conditions based on some information that we got for Johns Hopkins University, and we think that these are probably in the range of relative for many different universities, certainly maybe other types of schools as well. So we make some assumptions that we apply to all of the models. We assumed that the volume of the room was 150 meters cubed and that the breathing rate for everybody was 0.8 meters cubed per hour. The model, as it's provided, does allow you to account for different breathing rates of the infected person and the susceptible individual, which is nice, especially if you think about if the infected person was a teacher. Teachers who are up, moving around a classroom, talking, may have a higher breathing rate than students who are just sitting at the desk. relatively passively. So for this analysis, we just assumed that everybody's breathing rate was 0.8 meters cubed per hour. And then we considered 3 different risk scenarios. Our high risk case involves a relatively low air ventilation rate of 1.9 air changes per hour. We assume that the viral decay rate is negligible, that the emissions rate is about 500 quanta per hour, which is certainly an uncertain parameter, but from the Corral event, they estimated that the emissions rate in that event was likely more like 900 quanta per hour. So although, and then we assume that the duration of the class was 2 hours, which is kind of long for a university class setting, but certainly not unreasonable for what would be encountered in elementary school conditions. So what we're calling this a high risk case, 1.9 air changes per hour is certainly not the lowest that could be encountered in different types of classroom settings, and 500 quanta per hour is not necessarily the upper limit of what might be encountered, but might give us some reasonable end of a high risk case. The medium risk case was kind of the average air changes that was reported to us of 9 air changes per hour, a viral decay rate of 0.3 per hour, and a middle emission rate of 135 quanta per hour in a 1-hour class. And then our low risk case really has a high ventilation rate, a higher viral decay rate, and a lower emissions rate, which is expected to be something more like just speaking quietly among individuals. So maybe what would happen if during group work or something, if one person was infected during a 1-hour class. Next slide, please. So when we put this in the model, we looked at this as a function of the exhalation mask efficiency on the x-axis ranging from 0 to 100%. So this is assuming that the person who is infected is wearing a mask and accounting for the protection offered by the mask of that individual, as well as the inhalation mask efficiency ranging from 0 to 1 on the y-axis, which is the susceptible individuals all wearing masks with variable levels of protection factors. The shading indicates the probability of infection. So the probability of infection here was the highest for obviously 0% efficiency, basically not wearing a mask, nobody's wearing a mask. Down at the lower left-hand corner was about 84%. So this is the percent, the probability of infection for all susceptible individuals. And so the expected number of cases in this scenario could be estimated by multiplying that probability times the number of uninfected people in the room. So it allows you to think about, in a class of 30 to 100 to 200 students in a large, say, biology class, of how many students could potentially be infected if one person was infectious in the room. But of course, that drops quite dramatically as mask efficiency improves. Next slide, please. So for our medium risk case, where we assume that the emissions rate is lower and our ventilation rate is much higher, we get to a much more manageable, perhaps, level of risk, where even if nobody is wearing a mask, the maximum probability of infection is about 6% in this case. And then next slide, finally, our low risk case shows the same general trends. Here we had a much higher ventilation rate, a much lower emissions rate assumed here. And so the maximum probability we could round up to about 1% in this case. And so finally, on the last slide, I took on the next slide, we wanted to think about how long we should wait between classes. And so using this kind of a simplified model, you can also assume what happens as soon as an emission source leaves. So that person leaves the classroom because class is over. And then the air change rates continue, viral decay continues, and particle deposition continues. And so this plot shows, as a function of the air change rates, that concentrations will be reduced to about 10% of their average level, that well-mixed scenario that we estimated over the course of an hour class, for all air change rates exceeding 2.5 per hour. So this suggests that after about an hour between classes, we would expect the risk to be greatly reduced. And of course, this process could be accelerated by increasing your air change rate through opening windows or using other filtration systems as available. Next slide, please. So to kind of wrap up our thoughts on this, we wanted to put this kind of in the context of the different types of respiratory protection that we've been thinking about here. And so this is the same medium risk case that you saw before, and wanted to kind of overlay some of the mask efficiencies that we might expect to encounter in the real world. And so we can start at the upper right-hand corner with the nice green dot that says everybody wears an N95. And of course, in that case, our risks are really very negligible. But given the shortages of N95s currently, this is not likely to be a solution anytime, certainly not for schools returning to class in August or September. So instead, there's been a lot of discussion about whether teachers need to wear masks or their students can wear masks. Can people really wear them for a whole day? And what are the limits on communication while wearing these types of features? So in the blue mask, we kind of put a bound on what we think is a reasonable efficiency both for wearers and for the infected person wearing as well as the uninfected person wearing the masks for just your standard cloth masks using that data that Anna showed earlier. And so we think probably the best they're really going to do is about 50%, possibly more down like 20%. And so this range of the blue circle shows 2 to 3 to 4% risk per uninfected person in the room. There has been some talk about whether teachers could wear a face shield and students could wear cloth masks, and that might improve our ability for a teacher to communicate with students during the class. However, we think that the protection offered by a face shield is probably less than 10% in these kind of situations. There's some data that shows higher efficiency of face shields, but that really is only in this situation that's been tested so far of having somebody cough directly in your face. And while that may be important perhaps in preschools and kindergartens, I don't think it's a super relevant process, at least at universities. I fortunately have never had a student cough in my face. So thinking about a more typical situation in which you have ventilation and well-mixed aerosols in the room, really, I think face shields are going to offer very minimal protection in those scenarios. And so you're increasing your risk for the uninfected individuals in the room if for example, the teacher was wearing a face shield and was infected. And then the yellow circle down at the bottom really is showing that face shields probably provide very minimal protection compared to just doing nothing in the classroom, giving you very close to your maximum risk. Next slide, please. So our final recommendations based on the data that we've compiled in mask efficiency, as well as this modeling exercise based on this literature available model, is that to reduce risk in classrooms and really all sorts of other indoor environments where these same types of processes hold, we should be still encouraging students and instructors to maintain at least 6 foot separation so that we really are minimizing the role of droplets and only trying to account for aerosols. It's also important to note that that 6 feet separation really does provide some protection against aerosols, as well as because there is evidence to suggest that the number of viral particles that you inhale is related to severity of disease, that as we're standing farther apart, you're allowing for dilution of those aerosols from an individual to occur. So lots of reasons to maintain 6 feet separation. We should really be trying to, in all indoor environments, maximize the fresh air ventilation to the extent possible with HVAC units. Not all systems are capable of providing 100% outdoor air into the indoor environment, but that should be maximized to the best of our ability, as well as pairing these HVAC systems with the highest filter efficiencies possible. Preferably, we would like to see these systems using MERV 14 or higher. However, not all systems, especially older systems, are going to be able to handle the pressure drop that accompanies those types of filters. So it's important to make sure you're looking at the capabilities of any system before making those kinds of changes. Because it's important that airflow is going to still proceed through those filters, and as well as making sure that the HVAC system is well maintained, has a good seal around the filters, and in situations where perhaps this is not going to be a viable solution, that we perhaps invest in portable air filtration systems that maybe make use of HEPA or other types of filter technologies, might provide a cost-effective approach to improve ventilation in systems and older systems where it may not be feasible to actually replace the whole system. We should also be trying to maintain somewhat warmer temperatures in classrooms and try to maintain somewhat drier conditions. And we recommend that everybody should wear at least a fabric facial covering, if possible. N95s would be preferred, and that face shields, again, are not a substitute for masks. And then also, at least in universities, I think it's possible that classrooms should remain empty for 1 hour between sessions where you do have this high turnover of new people entering rooms all the time. Would allow adequate time for most systems that have reasonably high air change rates of at least 2.5 air changes per hour to have the concentrations within the room go down to about 10% of their peak levels. And I think that's all we have. So I'm glad we have enough time for a few questions. We'd like to acknowledge the co-authors that have been working on this analysis with us within our department, Pete DiCarlo and Gurumurthy Ramachandran, and then also Janice Ruggles, who's been thinking about this community protective equipment ideas with us. Thank you.
So thank you for thank you to Doctors Anna and Kirsten for an informative presentation. So now we'll move on to the question and answer session. We do have a few questions in the question box, so I will start. I think the first one's for you, Anna. It says, regarding N95 masks with exhalation valves, I have read suggestions that they are okay to use in community settings if you add a cloth mask to cover the valve. What are your thoughts about that?
Yes, I guess as long as you're giving that extra protection, then it would be okay. I mean, but having said that, just wear the cloth mask. It's going to be way less burdensome.
I also had one with a vent, and I just glued it shut. So that would be another solution too. Is I just put a drop of hot glue in there, and I think that probably is more effective than the cloth over top of the N95.
Okay. Great. Well, thank you for that one. So I think this question is probably for you, Kirsten. What is the period over which the probability of infection is calculated? 1 class period, 1 hour, or 1 semester? I guess that was.
So, and this is all the probability for a single class period, which for our high risk case, we considered a 2-hour class, and for our medium and low risk cases, we consider just a 1-hour class. So to really consider the cumulative risk over an entire semester, you would really need to multiply that by, 3 hours a week times 18 weeks in a semester or something like that, and to get to the really cumulative risk for the whole term.
Okay, thank you. The next question I think may be for either of our experts. So what about the gloves used during marketing? Are there any specifications advised so far?
Right, gloves, it's a very sticky issue. I think I shared this with Kirsten also. We don't think gloves are necessary at all. People don't need to wear gloves. First of all, this is a respiratory virus. So it's not a virus that you can contract through your skin. So wearing gloves will not protect you at all in that respect. If you're worried about a transmission from the surface to your face or, like a fomite, you're gonna do that with the glove or without the glove. So the important thing is not to touch your face or your mask and to so wearing a glove is not gonna give any protection. And honestly, the environmental impact of those gloves thrown all over the parking lots is huge. And so I have been discouraging people from wearing gloves because they have a very specific use in healthcare settings, worn by people that are trained to wear them in very specific situations.
Yeah, I think when you see them in common use out in the world, I see people wearing gloves, touching their phone, touching their wallet, touching their face, touching everything. And at that point, the glove isn't doing anything, and you haven't prevented contamination to all those high touch surfaces that you're going to continue using for the rest of the day. So it really served no purpose other than to create trash.
Okay, thank you. That's a good comment. Next question is about N95 type masks. So are unfitted N95 type masks significantly better than cloth masks?
I don't know that
I don't think there's a lot of.
Go ahead. Anna. I don't think there's
we don't. I think there's. Exactly.
I would guess that an unfitted N95 is probably still better than a cloth mask. But you do see occasionally people wearing N95s completely wrong. So that may not be universally true.
Okay.
I think, and there are actually pretty good videos on how to put on an N95. So if you do have one because you happen to have them from doing a home improvement project or something like that, you know, I think they're still hard to buy at this point. But there are some videos that can help you put them on. You know, you won't have probably any of the mask testing equipment, but to do the best job of applying it that you could.
Okay. So here's a related question to the N95 masks. And this one has to do with substantial facial hair. So can N95 masks be fitted properly on individuals with substantial facial hair?
No, and I think we know this from the occupational environment. In occupational setting, if you have facial hair, you are not allowed to wear an N95 because you will not be able to get a fit around your face. And so if you have facial hair and you're wearing one of those N95s, just consider it a community protective equipment. You're really not protecting yourself because particles are coming around the mask through the beard holes, and they are also coming outside of the mask into the environment. So they're not, you cannot fit test it.
If you only have a mustache and your mustache is fully contained within where the seal would be, then you're probably okay. But if you have hair overlapping where the mask is actually touching your face, you're not going to get a good seal at that point.
Okay, great. There are two incomplete questions here, so I'm going to skip those. Are you aware of any data on the performance of 3-ply non-woven surgical masks?
I found one paper that had compared a bunch of different surgical masks. They had tried both medical ones that are used in the medical field as well as ones that were used in the dental field, and I'm not exactly sure which type you're applying to, but they found that the material itself for the medical masks was really highly effective. For the dental masks was not as effective, but then you still have the leakage around the sides to contend with. So the actual protection factors are a little bit harder to know.
And I also, if I can add this, we know that the more layers you add, you're going to increase the filtration efficiency, but you're also going to increase the pressure drop. So it's going to be harder to breathe through it. And so probably what you're going to do is you force your air around the mask. And so we have to be careful about the more layers you add, it's not necessarily better, because there's a point where you just not able to breathe.
And that's an important point for homemade masks as well, is that you can attempt to make yourself a really effective homemade mask that then doesn't allow you to breathe through it at all. So if all of the air is coming around the sides of the mask, then it's really not doing anything. And so I've seen some kind of crazy designs online of companies making them out of silicone and stuff like that. It's like, you can't breathe through that. So all of the air is going to go through the holes. So what's the point? It's not, yeah. So that resistance that you feel when you're breathing is, although bothersome, is a good sign that you're actually pulling air through the mask.
Okay, good. This next question has to do with gaiters, and it says, do gaiters afford any protection?
I think the gaiters afford the same protection as a normal mask. It's like I said before, this hasn't been tested. So the fact that they go around the head may give us some protection, but the fact that they are made out of thin layer of fabric that in and out of the fabric. So I don't think there's any extra protection.
Since a lot of them are stretchy, it's possible they're actually providing somewhat of a better fit around your nose, which would be an advantage compared to some cloth masks. And also some of them are pretty staticky materials, but I think a lot of this is challenging, and that the efficiency of these masks, I guess, ranges between at least 20 and 50% for typical homemade masks, and the range might really be wider than that.
Okay, thanks. So this next question is from our colleagues out in California, and they're asking if you can generally talk about how you would balance the risks from the coronavirus and fire smoke as we enter fire season out in the West Coast.
In terms of ventilation?
Yeah, in terms of ventilation, outdoor versus inside, wearing a face covering versus not, just kind of the whole picture on health and safety.
I think the face coverings help you either way. They're not the face, homemade cloth masks are not 100% effective against viral particles, and they're not going to be 100% effective against the smoke either, but will probably provide you some amount of protection on the order of 20 to 50%, which may be important. I think probably the best advice during smoke season is the same advice we're always giving, which is safer at home. So then you could use your ventilation system. Hopefully you have a filtered ventilation system that you can use instead of just opening the windows, would be a good approach, as well as, yeah. Anna, I don't know if
the air purifier.
Yeah.
I don't know if in California they're using the air purifiers, but in Mexico City, when the volcano was erupting, air purifiers, are effective against those sooty particles.
Yeah. Air purifiers at home is a good option for both removing smoke particles and potentially viral containing particles.
Okay. This one's for you, Kirsten. The risk model assumed a well-mixed room. How might the results change in a large room or a room with a very high ceiling?
So the well-mixed room model should apply in both of those situations. But the important caveat there is that we are assuming that you're maintaining that social distancing so that we can somewhat neglect the role of those larger droplets. I think also in some situations you can have HVAC systems with inlets and outlets in which it takes longer for things to become well mixed, because you kind of develop eddies within a room, and so you can have zones where things maybe are not as well mixed. Those kind of things are always going to be a challenge to do with this kind of a model. You'd really need like a computational fluid dynamics simulation to count for those very specific room by room changes, which I think is not practical for very many situations. So the well-mixed room model gives us kind of a basis for thinking about decision making, whether or not the actual values, is 1% and 6%, but it's kind of giving you order of magnitude. The authors say this themselves, kind of giving you orders of magnitude ways to evaluate changes in different, conditions that you might apply of either mask efficiencies or changing ventilation rates.
Okay, great. And this question probably will be our last, and it's also for you, Kirsten. So it's talking about the back to your modeling and your low risk exposure. And it says, you touched on the idea of cumulative exposure. I believe in your classroom scenario, the low risk exposure had a 1% probability of transmission. Assuming that's true, would you consider this level of risk to be acceptable given that students take multiple classes per day?
I mean, I guess acceptable, all of us are taking different acceptable levels of risk in our daily lives. So I don't know that I'm the best person to make a decision on what's considered acceptable, because I think certainly that's different for a healthy young adult and perhaps their 64-year-old teacher who's about to retire, right? So I don't know that I'm in a position to say one level is acceptable and something else is not, but we could put things in that kind of a context and, you know, allow individual you know, school administrators to be able to make decisions. So that was really the goal of this modeling exercise, is to give kind of levels of risk that people can use for decision making.
Great. Well, thank you. And I want to thank everyone for participating in this month's webinar. Within the next day or so, all of our participants will receive an email asking for you to evaluate the webinar. Please provide your feedback. We're always looking for additional topics that people would like to hear about. The recording for today's webinar, along with any handouts, will be posted behind the members portal on the ISES website. And the final reminder is ISES has officially gone virtual for this year's annual meeting. Please register by July 31st and for early bird pricing, and we'll see you at the conference on September 21st. So thank you so much.
Thank you.
Thank you.